Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. September is Prostate Cancer Awareness Month. In the United States, 1 in 8 men will be diagnosed with prostate cancer in his lifetime. It is the most common non-skin cancer in the United States. On today's show, we will learn more about the causes and symptoms of prostate cancer, risk factors, prevention, and treatment options. We are pleased to welcome Dr. Malini Patel, Director of Medical Oncology at Robert Wood Johnson University Hospital, Hamilton, an RWJBarnabas Health facility, and the Rutgers Cancer Institute of New Jersey. Welcome to the show. Thank you, Dr. Patel, for being here. Before we start, so the audience knows a little bit about you, can you tell us a little bit about your background, where you're from, where you practice, et cetera?
Sure. So my name is Malini Patel. I am a medical hematologist and oncologist by training. I am from New Jersey and did much of my training in New Jersey. I did undergraduate studies at Rutgers University, followed by medical school at St. George's University. I did my residency training in New York City in the Mount Sinai system and was out in the Midwest at Loyola University for fellowship. And then came back to my alma mater. I was at the Cancer Institute of New Jersey in New Brunswick from 2017 to 2021, where I focused primarily on lung and head and neck cancers, and then recently became the medical director at Robert Wood Johnson Hamilton, a little south of New Brunswick, where I see all types of malignant or cancerous conditions, as well as benign blood disorders as well.
So for the audience to know, you basically a hematologist oncologist who deals with different types of cancers, including what today's the discussion, prostate cancer.
Correct.
So tell us a little bit about prostate cancer. Tell us about what causes it, if we actually know what causes it, and basically a history of what people should think about.
Sure. So, cancer is basically when there are abnormal cells that divide in an unregulated manner. After this happening for quite some time, they will form small tumors in organs, in this case, the prostate. And that is basically where prostate cancer would start. In more advanced disease, these cancer cells can travel to the lymph nodes. Our body has lymph nodes throughout our body, and that's normal, and they serve kind of like the highway system. And cancer cells can move to these nodes as a way to travel to farther away places. But in general, prostate cancer will begin in a confined space in the prostate, move to different parts of the prostate organ, and then can eventually move to the lymph nodes and other organs if it's allowed to advance. In terms of common symptoms of prostate cancer, we don't really see many symptoms. A lot of folks may not even know that they have prostate cancer because it's not causing any symptoms. In more advanced cases, as the tumors are allowed to grow, you may start feeling some symptoms, which I'll go over shortly. We don't quite know what specifically causes prostate cancer, but we do know that there are certain risk factors. So for example, age is the most common risk factor. As you get older, your risk of prostate cancer increases. We do know that some folks have a higher chance of developing prostate cancer based on their race. So African Americans and Blacks, for example, tend to have more aggressive disease or may be diagnosed with prostate cancer earlier. Certainly a family history or any genetic syndromes, but we don't know quite what causes prostate cancer, short of abnormal cells dividing in an unregulated manner.
So in men, we're looking, basically this is a men's disease because that's where the prostate gland is. We're looking at the just below the bladder, going into the urethra, is this gland called the prostate gland. In men who are younger, basically it helps function with when they're having sexual contact with their spouse. But other than that, in the younger people, it really doesn't contribute very much. As we get older, unfortunately, it sometimes increases in size. And when men get to be in their 40s, that's when we start to look at some type of screening for these men. In the past, we didn't have very much good screening. Basically, we would draw a blood test called a PSA on the person, and unfortunately, that PSA is not the most accurate of tests, and we'd sometimes get high numbers, we get low numbers. If they had a urinary infection, that could also increase it. So now that we've gotten into the year 2023, tell us what are the common tests and who should be screened for prostate cancer?
Sure. So certainly, if you have some of the risk factors that I mentioned, so African Americans and Blacks are at a higher risk of developing prostate cancer, so they they certainly should be screened. Family history is another big risk factor. By having male relatives with prostate cancer, you can increase your risk of prostate cancer by double to triple. So certainly if there's a family history, there are a few genetic syndromes that put you at an increased risk of prostate cancer. For example, if you are a carrier of the BRCA1 or 2 gene, you have an increased risk of prostate cancer. Now, some folks may know the BRCA1 and 2 gene are genes that put you at a higher risk of breast and ovarian cancer. And we often hear about its association with breast and ovarian cancer, and many females start screening for these cancers at a much earlier age. But there are some uncommon cancers such as prostate cancer and pancreatic cancer, which are also associated with the BRCA1 and 2 gene, where increased screening for prostate cancer is indicated. There's also a syndrome called Lynch syndrome that can put you at an increased risk for cancers such as colon cancer, breast cancer, endometrial cancer, and prostate cancer are some of the common ones. So if there's a family history, I would say, of any of these cancers, or there's a known history of family members having the BRCA1 or 2 gene or Lynch syndrome, I think I think screening for prostate cancer would certainly be appropriate. And then also, there's also certain environmental exposures that put you at an increased risk as well. Agent Orange, which was an agent that many Vietnam veterans were exposed to during the war, has been implicated with an increased risk of different types of cancers, prostate cancer being one of them. So if I have a patient in my practice or a patient in a primary care practice that may where they have a history of being overseas and served during Vietnam, then they certainly likely had Agent Orange exposure and certainly would be at an increased risk for prostate cancer, where screening would be appropriate. So I think you had asked about the tests that we use. Is that correct?
Correct. Correct.
Okay. So, in the primary care office, which is usually where screening starts, like you said, it starts with the PSA test, which stands for prostate-specific antigen. So this is a protein that's secreted by the prostate tissue that we can pick up in blood, and when it's elevated, it may be suggestive suggestive of prostate cancer. Now, it does have its limitations. It being elevated doesn't necessarily mean that it is prostate cancer. Like you had stated a few minutes ago, it could be elevated in benign conditions such as benign prostatic hyperplasia, which is that enlargement of the prostate as men age, and also in inflammatory or infectious conditions like prostatitis. So if you have a young gentleman that has an elevated PSA, then you really want to look more toward, younger than 40, 50, then you want to look more towards infectious causes. And if it's, elevated in an older gentleman, then it would warrant more of an evaluation. So other evaluations for screening also include a digital rectal exam. So that is where it's a physical exam where a physician or a provider will try to palpate or feel for the prostate and see if they feel any hard lumps or bumps, which may suggest that there's a cancerous tumor there. If either of those screening tests are abnormal or patients are having symptoms, further tests for evaluation would include things like an ultrasound or an MRI of the prostate, and then if any of those are abnormal, then you would require further work or perhaps a biopsy by a urologist.
So as a primary care physician, I start usually screening at age 40, usually after a discussion with the patient about the PSA. And so we're looking at a PSA, we're looking at the value of under 4 nanograms per milliliter. And we usually at age 40, we're getting a baseline. And then based on the discussion with the patient, since it is a discussion, we consider when we should repeat it. And most people usually repeat it approximately once a year. So we're looking for any changes in that, especially if there's an elevation of greater than 1.0 nanograms per milliliter in a year. If such a thing exists, or if the patient has any symptoms of something, usually at that point we refer them to a urologist. The urologist usually is someone who'll do the digital rectal exam on the patient, and then make a decision whether they do a ultrasound on them or an MRI on the person, or if they do the PSA where they break it down into free and total to see whether there's any concern about it. They then are the ones who then make some decisions along with whether there should be a biopsy or not, based on whether they see any nodules or any abnormalities. So the urologist finds something like that. Now, what we do is that the urologist now refers them over to someone like you, or someone over at the Rutgers Cancer Institute, or at RWJBarnabas University Hospital Hamilton to get treatment for prostate cancer. What happens when they are referred there?
Correct. So, like you were saying, the screening starts at the primary care office, and then they would typically be diagnosed, by a urologist. We do look at the tempo and how quickly that PSA is rising. If prostate cancer is diagnosed, there are a few things that are looked at in terms of the diagnosis itself. So depending on the pathological features, meaning how the cells looked under the microscope, one would categorize these patients into risk categories, and they generally fall into low risk, intermediate risk, or high risk. The first set of doctors they will typically see are a urological surgeon at the Cancer Institute. If evaluation suggests that there's no distant disease, meaning there's no concern that there's prostate cancer involvement of the lymph nodes or the bones, which are a common area where more advanced prostate cancer likes to travel, then they will typically see a urologist and a urological surgeon rather, and a surgical resection will be discussed with them. So typically, if surgery is undertaken, then they will have a robotic surgery, which leaves a small incision, and they will have the resection of the prostate. Alternatively, patients may also opt to get radiation therapy for their prostate cancer. So in most instances at the Cancer Institute, both options are presented to the patient, and they may see a radiation oncologist as well, and then a decision will be made as to how the patients would like to proceed. There are some side effects that generally tend to resolve within 6 months to a year with both modalities of treatment, which include urinary incontinence, meaning trouble with the control of your urinary function, and erectile dysfunction. But again, these tend to resolve, and the timing of them are a little bit different depending on whether one undergoes primary surgery versus radiation for their prostate cancer. Now, this is under the assumption that someone gets treated for their prostate cancer. In many instances, it may be appropriate not to treat someone right away for their prostate cancer. And I know that may sound a little funny, but most prostate cancers, fortunately, are diagnosed at a very early stage. And the majority of them act like lambs as opposed to lions. So they tend to grow very slowly. So as I was saying, when the prostate cancer is diagnosed, they're divided into risk categories. And if they fall under the very low risk category or the low risk category, or if a patient has other medical problems that they're also dealing with at the same time, it may be perfectly appropriate to go into what we call a watchful waiting or active surveillance strategy. And a radiation oncologist or a surgeon may also discuss that with the patient, especially if the disease is deemed to be very low risk. That does not mean that the patient is not followed. With the active surveillance strategy, what typically happens is patients get serial, meaning repeated scans, often MRIs, and serial biopsies as well to see if the prostate cancer is progressing during the active surveillance period or if it's changing in its risk category. And if at any time we see that those things are happening, then therapy for the prostate cancer would be undertaken. But it's not necessarily given that everybody that's diagnosed with low or very low risk prostate cancer has to have treatment for their prostate cancer right away, as most of these tend to be very, very slow growing, especially if someone is older and wants to avoid some of the side effects related to those, those two modalities. So that would also be a discussion. But again, this is more appropriate for people that have lower risk disease. Someone that has more intermediate or higher risk disease or does not have many medical problems or are young would typically undergo primary surgery or radiation for their prostate cancer. Now, they'll see a medical oncologist at the Cancer Institute or at any of our system hospitals if it's deemed that the cancer is higher risk and may need additional therapy to prevent the risk of it recurring. And what I mean by additional therapy is typically hormonal therapy. Prostate cancer strives in the presence of testosterone, which is a hormone that all males possess, and testosterone basically serves as food or nutrients for prostate cancer. So by decreasing your testosterone levels, usually via injections or pills, you will reduce your risk of prostate cancer. This type of therapy is also used for more advanced disease as a way to cut off nutrient supply so that the prostate cancer cells can't thrive. But typically for early stage cancer at the Cancer Institute, patients will start out seeing a urologist or a radiation oncologist for their early visit.
So the good thing at the Cancer Institute of New Jersey is the whole team approach, because it is a very difficult subject to talk about because there are so many differences. One, if the person is an elderly person, they're above the age of 85 and have multiple medical problems, and it's a low risk, watchful waiting may be the best course of treatment for that person. If the person's a young person, more aggressive treatment may be necessary, and there's so many different treatments. I've been in practice since 1985, and when prostate cancer was done then, it was a radical prostatectomy, and everyone ended up with side effects from the surgery. Now, with the advanced robotic surgery, using all of the new Da Vinci type of machines, it's minimal amount of side effects, and basically you may end up with some minimal stuff, but it's much lower risk of either the urinary incontinence or the erectile dysfunction. And if the person opts instead for the radiation, you have the external beam radiation or the implants. And then, of course, we also have the injections of the hormones. So you basically need a real good team to approach this, and especially if you're finding it in someone's 50s and 60s, because this is someone that needs to be followed for a long period of time. And that's the whole benefit of going to a place like the Rutgers Cancer Institute of New Jersey.
Correct. And so, even in earlier stage cancers, it's possible that you may need multiple modalities of therapy. So when you have the team approach where everyone is, under the same space and reviewing the cases together, it leads to better patient care, in my opinion. The other aspect that we have at the Cancer Institute of New Jersey is clinical trials. So for more advanced disease, which I haven't gone much into, but when the prostate cancer is diagnosed at a later stage, meaning it is spread to other organs or the bones, or if one was treated for prostate cancer a long time ago and it's returned in distant or faraway organs, people will need other types of therapy in addition to the hormonal therapy, which may include chemotherapy or more advanced testosterone reducing medications, which come in the form of pills, or even medications that work with your immune system to eliminate cancer cells. And whenever we see, in general in cancer care, when we see that the agents that we use in more advanced disease are effective, the next logical question that comes up is, can we use this earlier to improve the outcomes of earlier stage cancer or reduce the risk of the cancer recurring? So we have clinical trials at the Cancer Institute that also look at some of these agents that are used in, that would typically be used in more advanced disease from an earlier time point, and you may have access to these clinical trials, eligible, which may serve as the, a novel approach now, but the new future standard of care later on. So the clinical trial aspect is big as well. When you come to the Cancer Institute, with a new cancer diagnosis, you'll also be screened by our clinical research team to see if there are any clinical trials you are eligible for, where you'll have a detailed discussion with your doctors, whether they're the urological surgeons, radiation oncologists, or medical oncologists, to discuss what the rationale of the clinical trial may be, what the risks, benefits are, and patients will have the opportunity to decide whether they would want to enroll in such trial.
So what can a man do to reduce his risk or delay their risk of developing prostate cancer?
Sure. So, like I said, while we know some risk factors for prostate cancer, unless there's a new youth serum, I don't know about, you can't change genetic predisposition, you can't change your family history, your age, or your race. But there are other lifestyle modifications that may be helpful. Even though the data is mixed, we do know that smoking and obesity might slightly increase your risk for prostate cancer. So to abstain from smoking, Having a nutritious diet to avoid obesity-related complications may also reduce the risk of prostate cancer. Certainly, if someone is having symptoms of prostate cancer, which may include difficulty urinating or a decreased stream, any blood in the urine or semen, where they're having the urge to urinate more or painful ejaculations, that may suggest prostate cancer. So at that time, they really want to follow up with their doctor so that screening, if it hasn't happened, will be undertaken. Like we said, the good news about prostate cancer is most of them are diagnosed at early stage, and most of them do not tend to spread quickly. So if it's caught early, there's a very, very high chance of cure rate. So in terms of, prevention, I would say, abstaining from smoking, balanced diet, losing weight if you fall into the overweight or obese category. There is some data which came out in about the last 10 years or so, that there are certain medications that are used for enlarged prostate that many men are on, for example, Proscar, finasteride, which have been shown to reduce your risk of prostate cancer about 20%. I don't quite think it's standard that these medications are prescribed across the board. Many men, as they age and their prostate becomes enlarged and they have some of these symptoms that we talked about before that are not related to prostate cancer, will be on these medications anyways when they come into my office. But if you're not having these symptoms, there is some data of medicines like finasteride, which are used to treat benign prostatic hyperplasia and large prostate, which may also reduce your risk of prostate cancer by about a fifth or so.
So the important things are to keep yourself healthy, low-fat diets, plant-based diet if at all possible, screening for prostate cancer, seeing your primary care doctor. If there are any symptoms of any concern, consideration of a referral to the urologist. After follow-up with the urologist, the important thing is a referral over to the Rutgers Cancer Institute of New Jersey or to one of the other RWJBarnabas facilities, such as the one that you work out of Hamilton, in order to get the team approach to prostate cancer.
Correct.
And that everyone's treatment of prostate cancer differs, and it's going to be individualized based on the, whether it's aggressive, non-aggressive, the age of the patient, any other medical conditions, and that the team approach at Rutgers Cancer Institute is a wonderful one, and that it's so close to us that one does not have to travel far to get the best possible treatment and be able to be part of the clinical trials which are currently undergoing over at the Rutgers Cancer Institute. Thank you, Dr. Patel, for all of your information, all of your work in hematology, oncology, all the previous work that you've done at Rutgers Cancer Institute and the current work that you're doing at Rutgers Cancer Institute. And I hope, hopefully in the future, we can talk again more about these type of cancers.
Sounds great. Thank you, Dr. Shinsky.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical expert are not a substitute for medical advice from your own physician.